We had this trouble earlier today too, and I'm not sure. I'm just going to try next. I guess I can do it that way.
I know.
So I am co-founder and executive director of A New Path, Parents for Addiction Treatment and Healing. And we work to reduce the stigma associated with drug use and substance use disorders. And we advocate for therapeutic rather than punitive drug policies. I'm also the lead organizer of our Moms United to End the War on Drugs campaign, now going on 10 years. A New Path is in its 21st year. We have representatives in 35 states and 6 countries, and we put forth a lot of different campaigns throughout the year. I'm going to try to just, yay, it worked. So we're actually living in a triple crisis. We're in the middle of our Too Many Moms Mourning campaign. It's a triple crisis of COVID-19, opioid overdose, and systemic racism. Depression, suicide, drug use, homelessness, and overdose deaths are rising during these troubling times. And communities of color and poverty who have been disproportionately affected by the war on drugs are now even more at risk and vulnerable during the pandemic. I think I have some more people trying to get on, so let me switch gears for a second. No, I'm okay. Okay, admit. And hopefully Kyra not on, and Vanessa keeps trying to come in. Hi everybody, hope you're on. So the issues that we're going to discuss tonight are problems related to vulnerable drug-dependent populations at high risk of overdose, the critical need for medication-assisted treatment, MAT services, addressing stigma to embrace many pathways to recovery, to treatment and recovery, and the delivery of life-saving services during a pandemic requiring social distancing. So what we would love to see is a world where there is treatment on demand, right? I mean, that's our goal. And a philosophy that one size doesn't fit all. It would be wonderful if a person could go to the doctor, therapist, and have a whole laundry list of opportunities, including methadone or Suboxone or whatever, and we're able to do that kind of a one-stop shopping thing without any stigma associated, because we're all different and we all receive treatment and recovery in different ways. And so the problem, however, is still stigma. Stigma runs deep, not just in the community, the criminal justice system, of course, but also in the medical field and within families. So we just really need to stop the judgment about treatment and recovery pathways. We're going to be discussing the need for abstinence-only based programs to work in partnership with programs that offer harm reduction strategies and medication assistance treatment, with the goal of reducing stigma, increasing access to treatment, and saving lives. Caroline shared this slide with me today, and we'd like to share it with all of you, the principles of harm reduction. And obviously there's more than one path to recovery, right? And not everybody's ready to stop using drugs, but they need to stay alive or they'll never find recovery, right? So today we have some wonderful panelists. I'm going to be the moderator, which also means I'm the timekeeper. So each panelist will speak for 10 minutes or under, whatever they prefer. And we want to make sure that we leave a half hour for questions and answers at the end. So our panelists are Caroline Stewart, LCSW President of the New Path Board of Directors, Carla Marienfeld, Dr. Carla Marienfeld, MD, FAPA, FASAM, and many other things. Elon Burns, KDAC2, Drug and Alcohol Counselor and Board Member. Tom Horvath, President of Practical Recovery, Practical Recovery is a PhD. And Julia Negron is a CAS. She can explain what that means. And she's a board member of A New Path and director of Suncoast Harm Reduction Project. And so we'll be starting with Caroline. Please put your questions in the chat. April, our director of operations, is on the call and will try to help direct questions in the chat box. And again, we want to save time for Q&A. By the end of this training, we hope that you'll be able to understand the need for offering many different treatment modalities, particularly during the pandemic. And so now I'd like to introduce you to Caroline Stewart, and I will try to just tell me next when you want me to move a slide.
Thank you so much. Am I unmuted? Can you hear me? Yes. Okay. So essentially, I asked to be on this panel today because our family is currently living with harm reduction aggressively every single day. And I wanted to tell you a little bit about that. So I come to you wearing many hats. I am a mother of a 39-year-old son who has suffered from a co-occurring disorder for 25 years probably. I think I'm going to share a story with you. I wasn't going to share it if I hadn't had good news, but we had invited our son to dinner this evening after the talk, and we didn't hear from him for 3 hours. And so I'll be frank with you, I began to worry that maybe he had overdosed, because that's what we live with. He's been sober for 2 years. He's doing well, but when we don't hear from him, we become highly anxious, wondering if what's happening. And you might say, well, if he's sober, so what's going on? Well, here's the thing. I think COVID has complicated his recovery. He's been very stably on Suboxone for 2 years. He has had 18 months in sober living. He's had a very, very stable attachment to his AA community, but COVID has started isolating him. And his father and I have noticed that he's been lonely and a little bit more anxious and depressed. And so he moved into an apartment recently. His roommate, we're very fond of his roommate, but his roommate works full time and our son is not yet working. And so I think he's isolated. So I just wanted to say that this is a very vulnerable time for people who are struggling with substance use disorders, but particularly if they have an opioid history. So our son calls about 20 minutes ago before I came on the phone. I'm really glad he called, and he said he had fallen asleep, that he'd been up all night helping a friend move, and he had slept in, and he apologized. But I'm telling you, that's what our lives are like when we have long periods that we don't hear from him. It makes us very, very anxious. So besides being a mother, and my son has been homeless, he's been incarcerated, he has had major medical problems that are co-related to his opioid use. And he, for probably on and off throughout the years, had a polysubstance use problem. He's going to be facing a major dental surgery coming up. And you can bet your boots we're very anxious about that, because we're being told by the dental surgeon he'll need to be on opioids. So we're really anxious about that. So that's kind of what we're up against. I also come to you today as having taught anthropology for 10 years, some of it at McGill University, some of it Carleton University in Ottawa. And I think my point in raising that, why I even bother to tell you, is that social isolation is a big problem right now. We primates are so hardwired for social connectivity that I'm sorry, everybody, these Zoom meetings aren't right. They're not really cutting it. I think my son is struggling with the AA Zoom meetings. For one thing, he's learning disabled, and the technology is very daunting for him. And I think it's so much more intuitive for him to be physically around people. So just going to AA meetings on Zoom is not meeting the mark right now. And that does worry us. So I just mentioned that I'm an anthropologist because of our strong social wiring that would make COVID a particularly difficult time for those attempting to sustain sobriety. I will also say that as a clinician, Dr. Marienfeld knows this, but for over 20 years, I was on an intake team at UCSD outpatient psychiatry. And over the years, as one of the adjunct non-physician instructors, I have to tell you, over 70% of our intakes were patients, we were a psychiatric clinic, were patients with co-occurring disorders, meaning lots of people that have substance use disorders also struggle with psychiatric illness. And we have to address both of those issues. And I'll be frank, right now, it's very difficult to get aggressive inpatient care for severe co-occurring disorders. One of the things I do so hugely in my practice is work with parents like my husband and me who have adult children that are living with them who are in an altered state much of the time, either both from indigenous psychosis from their psychiatric illness and because of substance use. And it's not a good situation. These folks should be in long-term residential treatment that's therapeutic, that's containing, that's supportive, but they can't expect a bunch of old people, the seniors, to care for these adult children, and that's a big problem. So I really think we need to be more vigilant about co-occurring disorders. I have been co-leading the co-occurring support group at NAMI for the last 3 years, and I meet, sadly, hundreds of parents who love their children and want to be harm reductionists, but their children need a higher level of care. I'm also here tonight as a community activist, and I'm pissed off. I'm really angry. I'm heartbroken by our lack of housing. It breaks my heart to see downtown San Diego, Los Angeles, San Francisco look like Mumbai, where people are living on the streets without adequate community support. It's not simply putting the homeless with co-occurring disorders into the convention center is totally inadequate. And I guess the other thing I would say is I'm a housing first advocate, but that's not enough. Tragically, many of our clients that have been homeless that wind up getting housing don't keep it because they're kicked out because of hoarding, disorganization, just a general chaos, and they need very active, aggressive clinical case management. And finally, it's a kind of maybe not the most important thing to share with you, but I have been a victim of individuals who were not treated with harm reduction. My husband and I were assaulted many years ago. You don't need to know the details, but the individual that assaulted us was wrongly being treated in a punitive manner by the Justice Department. He was discharged from prison, and what he needed was aggressive clinical care because he had a severe co-occurring disorder. So I'm going to say one last thing. I think that we need to understand that there are what I call dueling mandates between the whole issues of abstinence and gratification. So harm reduction is about understanding that we cannot always live with pure abstinence. I'm a woman who struggled my whole life with maintaining my weight, trying to keep it attractive and a healthy weight. And, sometimes I can go for years not having some kind of, like, maybe I remember once going for several years and having no carbs. After a few years, I can't do anymore. The abstinence is too depriving. So I think abstinence may find the individual more cogent, yet more lonely. Abstinence may inform a sense of a higher moral order while fueling biological anxiety. Abstinence may provide a high degree of structure in one setting, say an AA meeting, while not preparing the individual for a lower level of structure, as in one's work site or home setting. Abstinence may find the client celebrated by family, yet estranged from one's social cohort. I think our son has, I don't like the word, I apologize, it's not harm reduction language, but our son in the past has relapsed. And I strongly believe the relapse was related to him needing to go back to people that accepted him emotionally and socially. That the relapse wasn't only about needing the drug in his brain, but about the social connectivity. So those are some of my comments, and I will turn it over.
I had one more slide if you wanted to.
Do I have time? I didn't want to say, I can say that.
Oh, you're such a good girl. Yeah, you have 30 seconds.
Okay, I was just going to say that after our son had been in very successfully, had been a very compliant individual, taking MAT in his sober living, he and all the sober living individuals were tested for COVID on a rapid turnaround COVID test. And our son came up positive for COVID. And it was tragic because his father and I, and we're in our 70s, we were called to the sober living to take our son was evicted. He was evicted with no time to find housing. My husband and I had to find housing for him with no protection. So that, in the end, it wound up being okay. Our son went to an apartment, but I'm telling you, it felt very much like a triggering for being rejected and kicked out of sober livings in the past when he had relapsed. So I really think we need to have a more humane, kind of complex understanding of how COVID, we have to have places for people to live. If you're in sober living and you come up positive, maybe there should be some extra cottages or something, but simply kicking people to the curb, you're going to put people at high risk for losing everything they've worked so hard to maintain. So that's one of the main problems I'm worried about with COVID. Okay, thank you.
Thank you. So Carla, you're up.
Well, I appreciate you all inviting me, and thank you very much for the opportunity. Caroline, I think you did such a nice job of illustrating the experience that you have as a parent and as a concerned loved one, as well as the experiences that your son has had living in recovery during the COVID pandemic. And so it highlights a lot of the issues. As a clinician, we see patients coming in who are seeking treatment in the setting that I'm in. And so the perspective I have is of those who have either themselves, ideally, or through concern from family or friends, have recognized in some sense that there's a problem and that they are hoping that there might be things that can help them with that. And so that's the population that I see, and that's really what I can speak to. I think, however, there's a lot of people who don't have access to treatment. In particular, I 100% agree with what you say about the under-recognized role of co-occurring psychiatric disorders with addiction, and how that is also dramatically undertreated. And they certainly, it's a bi-directional relationship of how those two things influence each other. But I think it's well documented that there's an enormous treatment gap for people who would benefit for treatment for substance use disorders and for mental health, and those who get it. upwards of 90% of people who might benefit don't have access. And that's when we're talking about medications, that's when we're talking about therapy. You know, you mentioned sober living environments. There's the whole gamut or continuum of treatment that's available that most people will never utilize. And it doesn't mean all of those people are doomed to terrible things. Many people will recover and do well and connect with community supports and find ways to succeed. But many of them would do better if they were able to access treatment, including medications and treatment that is informed, I think, by a harm reduction approach. The challenge that we see in patients coming in for treatment is that we see these interesting sort of ebbs and flows. And even though I just quoted that about 90% of people don't have access or don't seek treatment who might benefit from it, we're seeing all kinds of numbers trickling in of the effects of the COVID-19 pandemic on substance use, one of which is that now that number might even be 92%, I saw recently. So there's actually fewer people who are able to access care, and yet we're seeing enormous indicators that more people are needing care. And those indicators include things like increasing overdose deaths, so certainly the worst possible outcome. We're seeing increased use across all different types of substances, across all different types of populations of people. So we really are seeing a lot of indicators that more people are needing care at the same time that there's less care available. And you highlighted, Caroline, I think some of the reasons why there's less care available. So because of social isolation and restrictions, we can have fewer people around, fewer people together, fewer opportunities for in-person care. And it's really a challenge. And yet it's interesting on my side because we have weeks in the clinic where we have all these new patients coming in, and we just don't know if we can manage them all in a timely way that would be most helpful to them. And then we have weeks where it's really kind of slow and fewer people are coming in, even though I know the need in the community is great out there. And so it's interesting to see these ebbs and flows of knowing the needs out there, but when people access it, when they make the decision to come in, when they try to see if they can find anything, you know, it's really a complicated situation, and there's a lot of factors, all of the different social determinants you mentioned and other things that influence that. What I think is interesting about the pandemic is not that the issues are particularly new. I mean, there are some new things. Learning how to feel connected via technology is a new-ish thing. But a lot of what it's done is just, as they say, rip the Band-Aid off. And so we're seeing the intensity of what we already knew was there increased. And that's what happens when you have the social isolation. You have increased anxiety, you have increased depression, you have increased loneliness, you have fewer of your normal methods for managing and for doing things that help you with your resilience. All of those things are less and less available. And so that's why I think we see this intensification of things as opposed to the, you know, I'm hesitant to make too much of an overgeneralization because we are seeing some things shifting. For example, in San Diego County, we know we're definitely seeing an increase in fentanyl in the past few months, particularly in the methamphetamine supply. And so that's having dramatic differences in what people are struggling with and what they're coming in with. But so it's not exactly 100% the same. But my point is, it's intensifying a lot of the things that we already know are there. You know, it's said often that addiction thrives in secrecy. And I would say what this pandemic does is it creates more isolation, more secrecy, more of that lack of social integration. It's also said that addiction is the opposite of social integration in many ways. And I think that that's a partial truth for a lot of people. And so we see that based on what's happening because of the pandemic. One of the things that I think is interesting in response to what Caroline was saying about the challenges with the AA meetings via Zoom and the challenges of talking to your doctor via Zoom. These kinds of things are really an enormous barrier for patients who I have an established relationship with. The Zoom part hasn't been too bad. You know, we know each other well enough. I can sort of get a sense for how they're doing, what's going on. It's certainly not as good as all of the body language you get and the nonverbal communication that you get when you're in person, but it's okay, more or less. But for new patients, patients you don't know well, it's really a challenge. And I do look for silver linings, and there's been some interesting reports by patients and articles and things like that about, are there any silver linings? And I do think that the change to having telehealth available as an option actually is a huge silver lining, because for a lot of patients, they weren't able to come into care before because of transportation reasons, because of location, because of whatever all the reasons are. So I think it is a silver lining to have that as an option, but we have to recognize that it's not a universally good thing all the time. Another silver lining is similar to what you had said around AA. I have actually a number of patients who found meetings that they really like that they otherwise wouldn't have been able to attend. Some patients actually say they like looking at the faces of patients in Zoom meetings versus you know, sitting in a room looking at a speaker, for example, as one other model. So I have heard some of these kinds of silver linings, but I do think that while those things might be changing things, ultimately there's a lot more that we've lost that we want to make sure that we try to find ways to regain. One of the things I was going to say just about the virtual nature of everything these days, whether it's our visits with patients or whether it's these kinds of meetings or socially with people, I was reading an article actually just recently about the importance of just being with a patient or a client, or however you want to call it, but just that process of being there and accepting and understanding, listening, reflecting what's going on, and just how critical that is for recovery and how much that is valuable for developing that therapeutic alliance that allows you to work with the person, that allows that person to be seen, to be heard, to be accepted, and to start making their own path towards recovery. And so I think that ultimately is a huge part of how people recover and the therapeutic relationship we can have and we can offer people from my perspective as a physician, that we're learning how valuable that is and trying to find ways to recreate that, but it's not always the same. And so that, I think, ultimately is what we need to be able to return to, hopefully, as we can. And probably over time a little bit, I can comment on the other things, or if you'd like to wait and I can talk about some of the vulnerabilities and MAT and those kinds of things and stigma in the discussion. Just let me know your preference.
That sounds great. Well, I'm sure that will be part of the discussion in the Q&A. So thank you. Elon is our next speaker. Elon?
Yeah, okay, sorry, I had to unmute myself.
Okay.
Hello, my name is Elon Burns. I've been a counselor and a caseworker dealing with substance use disorders for about 15 years in many different settings. And I actually did multiple years in abstinence-based places. I've done multiple years in places that are mostly abstinence-based, but that are using MAT now over the last few years. And I've done multiple years in what they call narcotics treatment programs, which would be your methadone, Suboxone places now. MAT, medication-assisted treatment. You know, we have a disease. There's a medication that's scientifically proven to help. It gives successful rates. And for some reason, there's still a problem using it. You wouldn't have any problem with any other medical problem being medicated. Lord knows we medicate every kind of problem. We invent problems that we can medicate. But for some reason, you know, medication-assisted treatment, there's still that stigma that I hear. Stigma, stigma, stigma. Stigma actually kills people. It really does. Stigma kills people. Why do you think people don't want to give the medication? Because we still have that underlining thing of it's willpower. It's under their willpower. So let's not give them medication and make it easier for them. You know, there's people that do it abstinence wise. Can't they do it that way? They just don't want it enough. They just don't try hard enough. All these kind of things come from that still stuck. Maybe even people that say it's a disease stuck back in the back of their head that still says, no, it's partially their willpower. It's partially they don't want it. It's partially they're a failure. And we really, I'm going to harp on that as I go through this, because we really got to stomp that out. They were mentioned. I love 12-step programs. I think as a guideline towards cognitive and behavioral change, I think it's one of the most outstanding things that have happened in the last 100 years. You know, it's a great tool for behavioral change. But there's stigma in there too. I mean, you've always had people like, you know, Alcoholics Anonymous never wanted to recognize Narcotics Anonymous because they just drink and they're not the druggies and that kind of stuff. And, you know, as much as MAT helps, the medication alone does not give you the success rate. It's medication plus the therapeutic support you get from a therapist and from a support group. Now, I have to have a support group to go to. And if I don't feel welcome to go to it, then I'm not going to go to it. You know, and too many times at 12-step meetings, people are forced to lie, which brings about the disease, you know, grows in the dark, you know, or they, you know, or they tell their truths, which you need honesty to get that, you know, cognitive behavioral change. You need to really get the social support you need. You really need to be honest with that support group. And then you risk being shunned by that 12-step meeting. So we need more openness for people to be able to get with that community. There needs to be places they go to get that community. And it really, it's made worse because when someone's in that position, whether they're starting abstinence-based or MAT, they know they need that social support and they need to jump into that, but it's really uncomfortable and it's scary. And so if I'm gonna, as an addict, I'll speak for myself as an addict and what I've seen from clients, my head's gonna come up with a zillion reasons why I don't have to be uncomfortable, why I don't have to join that support group, why these people aren't there for me, whatever. If we can reduce the valid excuses they have so that they're able to get the support they need, we're just going to increase the success rate all around. When we talk about MAT, we're talking about usually three things. You got buprenorphine, which is what you get, you know, your Suboxone. You got the old school methadone, and you got blockers, which are naltrexone. Now, I'm going to start with the buprenorphine and methadone because they're way different than the naltrexone. Now, these are opiate agonists. What they do is they go into the receptor on the brain and they fill the spot that the opiate you would be taking, whether it be fentanyl, heroin, Oxycontin, Vicodin, whatever your drug was of abuse from opiates. It's going to fill that receptor and it reduces the craving because it fills that receptor itself. Now it's long acting, so it can stay in there, you know, and let you pretty much moderate without ups and downs for the whole day. It is an agonist, so it is, there is, especially at the start, there is a slight change in it. There is a slight euphoria at the start, but really what it does is it fills that receptor to reduce the cravings. As for methadone, you know, it's usually taken every day, but you have to take it at a narcotics treatment program, which has the, you know, non-benefit of you have to go there where everyone else goes, and you feel the stigma of being at a methadone clinic, and you've heard all the terrible horror stories forever, and the people look down on you and all that kind of stuff. Now, if you're clean and you're doing, you know, you have to, like I say, you have to use it with the program. You'll have to get counseling while you're there. If you do, and you're testing clean, you're using your medication wisely, and you're not using other drugs, you can get it to where you can get up to a month's supply take home with you so that you don't have to be there all the time. But that would be the only place they dispense it. Buprenorphine, now they dispense it at the narcotics treatment programs, but you can also get it at a regular doctor's office if they've had the training. It's not a very long training, but a lot of doctors and healthcare workers are taking that thing, and you can get it prescribed there so that you can get your prescription without having to go to the narcotics treatment program as it is. Again, that's an agonist. It's got that fits in the receptor, but it's also got a partial antagonist in there to keep you from really abusing it. There's a certain level that you get to with buprenorphine that you're not going to get any more benefit out of it. You can't really abuse it because the blocker is going to kick in and keep it from filling any more on that receptor. The other one on the mat is naltrexone. Now, for the life of me, I don't really even know why it's included in MAT, except for it is a medication. But this medication has no effects at all. It's a total blocker, which means instead of going in the receptor and filling it like the opiate would to reduce craving, it blocks that receptor so that you cannot get high. What it does is it's going to be like a preventative against someone who's going to relapse, because when they play it through their head, if they try to relapse, the drug that they're trying to put in their system cannot make it to the receptor in their brain. So you cannot get high at all. So it's like an insurance policy for them that if they're feeling a little squirrely, they know that they can't run to an opiate, to the fentanyl, to the heroin, because they know it's not going to work. Now, that can be taken as a pill every day, but a lot of times it's taken as a 30-day shot. Also can be very effective. Obviously, and there's downfalls to that too. It depends on, everybody's different. Each one could be good. I think we need to be open to all of them. Some people, buprenorphine works the best. Some people have been on buprenorphine but have found methadone works the best. Some people, naltrexone's probably the most widely accepted by the abstinence-based community because you're not taking anything that has any effect on you at all. Naltrexone can be dangerous in where you better not have any opiates in your system, because if you have opiates in your system and you take a complete antagonist, you are going to get violently ill, because what it would do, instead of just blocking the receptor, it would jump on the receptor and pull all the remaining opiates off it and put someone into let me think about it. Okay, so
Elon, do you want me to forward the next slide?
oh, you can. Sure. Did you just already do?
Yeah, just the myths about medication-assisted treatment.
Okay. But yeah, so we need to be open to this, because more research is coming, and it took forever for the research to come in because of stigma. There's so many people, the same stigma that everybody wants this perfect world. They say, well, why can't everybody just do exactly the right thing? I'm sorry, it doesn't work that way. Why can't everybody just straighten up, pull themselves up, and never use drugs again and be okay with it? It'd be great. I wish everybody was happy and content with just sunshine. I would love that to be the world we live in, but it isn't. In the meantime, we're making judgments on people who are dying out there. And, as a counselor, I love abstinence-based if it works for you. But even as a counselor and in the field, they're doing a lot of counseling to counselors about how to be open to MAT, because we all have our own internal prejudices. And a lot of people that have been working in the field forever that might have got clean in an abstinence-based facility thinks that's the only way to go. They start to preach the one they know, and maybe some some judgment, some stigma about other forms of treatment get in the way. And even if you're taught, oh no, you have to be open to it because that's what everyone's teaching now, that MAT is successful and we have to be able to counsel for that, and we have to provide that, and we have to be open to that. People in subtle ways make it seem like you're cheating or you should get off it right away. You're just creating one problem for the other, when the reality is it's stabilizing people. It's getting them back in their family's life. It's, you know, keeps people out of prison. It has them working a job, and it stops the cognitive madness that chasing drugs does on an everyday basis, so that they can actually get the behavioral change that is necessary to actually live a productive and clean life. You know, cut back on overdoses, which I was hearing earlier about how much they're going up. Of course they are. We, you know, we are social creatures, and people in recovery, whether MAT or abstinence-based, whatever it might be, they need that social support. The problem is they need that social support, but the disease part of them wants to avoid that social support at times. That's where the disease grows. That's where the addiction grows, is in the dark. And a lot of times we are comfortable in the dark, and if we don't have to see that support group, so of course it's going to do it. I have a sober living, and I make my people go to meetings, and yes, there's some meetings that are still open outside. Since we're in San Diego, thank God we have bonfire meetings, but the computer ones is good. It's a substitute. We can take what we have, but a lot of times new people like the computer meeting because they don't really have to be involved, and we need to get out of our comfort zone, because they really need the social support. And social support, great, you can get it from your family, maybe you can get it from normies, but you really got to get it from the people that are also walking this walk, and someone you can be totally honest with, and someone who's going to support you on your journey.
Thank you,
That's all I
Elon.
have to tell Kristen and answer.
Yes, that's great. And now Tom. Tom, do me a favor and tell me when you'd like me to change your slides. Okay, just say next and I'll do it.
I will count the numbers as we go. So I could only come up with 12. I didn't start with that number. I began to think about the treatment system and the healthcare system and the society behind these specific changes that would need to be in place. So, number one, this is often not discussed, but most people, certainly many people, and possibly most people who resolve addictive problems do so on their own. The folks who have a harder time doing this often have multiple problems, as we have discussed. And what's interesting is that medical care operates from this foundation. You wouldn't conduct surgery, for instance, on a patient that you thought couldn't actually heal herself or himself from the surgery. And we need to take the same approach in dealing with psychological problems and addictive problems. Number two, it seems to me that if these conditions are life-threatening, then it makes sense to use very highly qualified providers, but an entire range of providers. I think we're seeing in recent years the proliferation of recovery coaches who provide a very important component to service, but often having a one-on-one relationship, typically with a therapist, but it could be a coach, is a crucial step for people. Now, one of the ironies of this recommendation is that there's no evidence that I know of that being very highly qualified necessarily makes you a better helper. Even those without extensive training can be excellent helpers. One thing I think should be added to that, though, is when problems start to arise, training can be very helpful, and it keeps highly qualified providers out of things like dual relationships and other problems that someone without training might fall into. Number three, this is where harm reduction comes in, because we if guided by the client's goals, will always be working from the perspective of the client. And I'd like to, in the bottom bullet there, talk about what Smart Recovery has done just in the last year. It's finalized this position. We have announced that our focus is on stopping problematic addictive behavior. And that focus is as the participant understands it. So to be very specific, I could decide that my alcohol problems begin with the first drink, so I'm going to stop before the first drink, or that they begin with the third drink, so I'm going to stop at the second, or they begin at the 10th drink, so I'm going to stop at number 9. Now, those roughly correspond to abstinence, moderation, and harm reduction. The approach won't make sense from a 12-step perspective, I understand that, but the part that really makes sense is that everybody in a Smart Recovery group can be focused on the same outcome, which is stopping, as they understand it, either for substances or activities like gambling. And this brings a unanimity to the discussion. It doesn't exclude anybody. In fact, I would say that everybody on this call and in the world has stopping goals that we're pursuing, whether it's not the second dessert in my case, or not the first dessert, or I guess I should say the third dessert in my case. But whatever the stopping is, I think we all pursue that. And of course, clients have goals about their entire person, not just the substance or psychiatric disorder of interest to the provider. Number 4. We've talked about this already. Multiple pathways means many doors, no wrong door, all kinds of services without pushing someone to a different or higher level of care. If we could remove the profit motive from treatment, that would help a lot. I'm typically dismayed by addiction treatment centers because they put so many roadblocks in the way of somebody accessing treatment. In my own case, our clinic, we only have one major requirement, which is you have to pay us. So that eliminates most people. Other than that, we provide, we require very few things. Number 5. This is a part that is almost completely left out of our system. Families are eager for help. There is an evidence-based option called CRAFT, Community Reinforcement and Family Training. Community Reinforcement and Family Training. It is approximately 3 times more effective than intervention, which is more well-known because it has its own TV show, or Al-Anon. And if we could put an army of craft-based therapists out in the world, families could access this support and start making changes in the home environment that might make a big difference for their loved ones. Number 6. This is starting to be done, embedding behavioral health into health care, and there's training that's required. The importance of this is that many medical problems have a behavioral health component. I've used the term here behavioral, by which I mean combining addictive, psychological, psychiatric. I think it's a better term because all these things go together. So where this is done, we hopefully can get to people sooner and reduce costs. Number 7. Our system tends to emphasize residential over outpatient, but it's recovery in the community that makes a difference. Most people can be successful while in a residential program. They have an enormous amount of support, and I'm not opposed to having people in them. I've owned and operated 2. I do think that they have a place. But most people do not need residential care. And there is no evidence that it is more effective than outpatient care, except for the population that can't afford it, which tends to be homeless, and they rarely get to have it. So for most people, outpatient would be fine. Number 8. If these kinds of ideal changes, you might say utopian changes, I'll accept that as a criticism, were to be implemented, then it would require a significant investment at the beginning, but presumably we'd start to have what's called cost offset later. We'd have smaller prisons, we'd have lower medical costs, assuming we made a major commitment to making this transition, which is probably a 5 to 10 year process. I'm not an expert on that part, but we'd need to spend more at the beginning. Number 9. I think we need, just as we're talking about the 3 W's now, wear a mask, watch your distance. What's the third one? It's terrible. Anyway, there's those 3 W's to deal with COVID. Julia can mention them later. These are the, wash your hands. Oh, how could I forget that? Thank you. Well, that was a good nonverbal message. Many people resolve addictive problems on their own. Your decision to change is the most important part. And I do tell this to clients. If you need assistance, call us. If you use substances, inform others, stay near them, and have naloxone if appropriate. You are safer that way. Now, naloxone is almost always appropriate unless you're drinking alcohol, because otherwise you're not sure what you're getting. And you might need the naloxone for it. And I threw in one from psychiatry. Even if you are about to kill yourself, that feeling will quickly pass. Call us to talk. These are the kinds of messages that might produce some results, even though any single message is not highly powerful. Collectively, they could do a lot. Number 10. And of course, we need data. We have, this is a relatively good part of the system we have, but I'd also love to see these published, just like you get the Dow Jones Industrial Average every day. There's, I think it's Nepal that has the unfortunate name of measuring gross domestic happiness. And I think it's a meaningful number in that country. Number 11. Such a behavioral system needs to be part of a larger healthcare system. We need to eliminate cost as a factor. Obviously, we have to pay for it, but we should pay for that collectively. We should be careful about the kinds of services we exclude, because sometimes you need to do unusual things to make something work. We already do ration healthcare. We could do it more equitably. Number 12. And I saved the most controversial stuff for last, because then I can run away quickly. I think we need to focus on underlying problematic situations, and I've described a few. We need to take the perspective of not what's wrong with you, but what happened to you, and provide the relevant help. And we need to support parents better, but also limit who can be a parent. And for some reason, the notion that we could control our population seemed to leave the public discourse decades ago. And I think it's time to start talking about it again. And when I talk about limiting who can be a parent, I'm not talking about anything mild. I'm talking about the sorts of things that lead CPS to take action. Like maybe those folks shouldn't have had children in the first place. I think it's worth discussing. And you can put me into my final slide, Gretchen, and I am finished. Thank you.
Thank you, Tom. Yeah, I think some of your comments, the last comments, might come up in the Q&A. And Julia.
Oh, no wonder you asked me to unmute. Okay. Gretchen, how long are we supposed to talk?
You have 10 minutes. We're running about 8 minutes behind, so whatever you're comfortable with within 10 minutes.
Okay, I can I can do that. I can do that. CAS, that is a master's level certification, certified addiction specialist. I, however, do not have a master's, and I was grandfathered in because I'd already been working in treatment 10 years when the certification started. KDAC was just starting up. This was another one, which is like weird when you think about it, right? Because Tom is an idol of mine, and what he said is true. We really need to have more expert people and not people that are opinionated by their own life experience working in treatment. It's a problem for me. Anyway, last night I was on a Zoom meeting with 500 people, a Zoom meeting that was one of my regular AA meetings in Los Angeles when I lived there. I'm in Florida now. And I took my cake virtually for 35 years of sobriety, which is pretty amazing. But for me, that worked. And I got to tell you something. I don't know why. To this day, I don't know why. But I'm going to give you a brief outline of how I ended up working in treatment. And I could tell you my background, but it's kind of irrelevant. It led me anyway to a hellacious opioid heroin addiction for decades. And I used to identify as, hi, I'm Julia, and I'm a dope seeking missile, because that was what my life was all about. And when I went into rehab, which was 1985, it wasn't my idea. I pretty much got pulled in. My husband was in entertainment and he was on the road, and they had pulled him out of his band and put him in treatment. So some poor road manager had to come to the house and grab me and get me in treatment, and we went. And I had no intention of staying around any of this recovery stuff. I just didn't get what the point was. You know, as long as you could come up with enough money, why was it anybody's business what we were doing? And the whole concept just kind of grew on me. I had been on methadone maintenance for about 11 years. And using every day on top of it. And so my detox was very long. I was in the hospital 5 months total at Cedars-Sinai in Los Angeles. And in the meantime, I became involved in the 12-step community. And that mostly, I consider myself very lucky, because in Los Angeles, they're really vibrant 12-step community. It's not, you know, I've been to meetings all around the world, and there are places where you go into a meeting and go, you know what, I'd rather put a gun in my mouth than sit through the rest of this meeting. I mean, it's very unique. If you find your people, if you find your group, it's great. And it's a mutual aid support group. Anyway, so I've been sober all these years, and I got involved in working in treatment. And I wanted to bring that up because we were talking about pathways to recovery. And in the 80s, it was all about tough love. And I was a tough love counselor in the Santa Clarita Valley. And we used to tell parents to take doors off hinges and send their kids to other people's houses and do all these crazy things to try to stop kids essentially from using. And it was all about deprivation. It was all about how much shit could you take away from them before they would be so miserable that they're just going to do everything you say. And that's going to be abstinence, and that's going to be going to meetings. And that's the way we were trained. You know, that's the amazing part. That's the way we were trained as counselors and in those days. And so I started working in chemical dependency units and hospital-based treatment. A lot of years. And, you know, there just was a point where things began to change. And I don't know exactly when that was. That's why Tom's kind of an idol of mine, because when I first heard about practical recovery, I was so impressed because it was so different from all this stuff that had been pounded into our heads for so many years that we've been passing on to families and other people and telling them, you know, how the cow ate the cabbage. This is how you do it. This is what you do. And it really was, like I said, your opinion, your life experience was what only thing you were giving out. So we're basically like not using any really clinical sophistication, not understanding anything really about addiction. And you know, when you when you really come to think about addiction as an acquired disorder of brain structure and function, and you understand that people are different, then all of a sudden a door opens and you go, wait a minute, just because I was able to do this, maybe someone else can't. Maybe someone else is different from me. Maybe their experience is different from me. Maybe their brain is different from me, and their body and their circumstances and their housing. And maybe they don't have a car. Who the hell knows, but everybody's different. So I started really doing a lot of educational seminars and things to learn about harm reduction, to learn about medication, it was like a shock after being an abstinence-based counselor for so many years to really have doctors standing in front of me telling me, you know what, methadone is the gold standard of addiction treatment. It is the gold standard. It is the thing that works most for people with opioid use disorders, that gives them a quality of life. This was like all new information to me. And eventually I really, I started to change. And as I started to change, I started to change where I worked as well. I was no longer working in chemical dependency units in hospitals. And I started working in, well, it sounds silly, but in Malibu, where in some of the private rehabs, you had the ability to think outside the box because it was private pay. It wasn't, insurance wasn't, in the mix at all. Okay, fast forward through my life story. So, I started working in adolescent treatment. That's where I started as a counselor. And I mean, in those days, there were locked units and we had to be trained mostly in professional assault response and in how to take down kids and how to, put them on gurneys and strap them down and have the nurses come and attend to them. And it was just craziness, and I used to vow to myself, I would never do any of those crazy things to my kid. Well, I did, is the point. And one of the reasons that I met Gretchen is because we'd both been in this world where our kids had, grown up to, in her case, definitely not genetic. In my case, probably, but our kids had grown up to have these drug problems. When I speak, I always say my son was my greatest teacher because it wasn't just that he opened my eyes to the reality that not everybody is the same and not everybody's brain is the same and not everybody needs the same dose of this or that. But he opened my eyes to harm reduction because whatever I was telling other parents to do for the longest time, I couldn't do with my son. I was not willing to stand over his grave and watch, and have him die. You'd hear in an Al-Anon meeting or something, well, some of them have to die. It's like, nope, not okay. So, I mean, things changed for me. And I mean, believe me, with my son, we tried it all. I know Caroline's been through this, Gretchen's been through this, a lot of us have. And we did everything. We paid people to kidnap him and take him away. We did intervention. My kids always tease me that I'm the most nationally known enabler of all time because I've been on TV enabling, and it's true, I have, because I'm a proud enabler. When I realized that I wanted my son to live no matter the circumstances, it no longer became important to me whether he was using drugs or not. What mattered to me was he safe or not? What mattered to me was he in prison or not? I had seen him on life support. I had visited him in prison during multiple prison stays. And so for me, it was really important that he was safe. So I got really involved in harm reduction. So what you see in the picture there is, me and my son, who has been, quote, in recovery. And I just want you to know, my definition of recovery is you're in recovery if you say you are. If you tell me that you're in recovery and you feel like you're in recovery and you're having 9 drinks instead of 10, good for you. Hallelujah. I'm no longer going to be the sobriety police. And that son is now 5 years thanks to medication. And I don't even like calling it Matt because it almost starting to sound stupid to me. He's on medication. The other people you see in the picture are the family members we lost to overdose. My sister, my mother, my daughter-in-law. The little boy in the picture is my grandson who now lives with me because his mom is gone. So all this work we do is really important, and the different pathways are really important. And the fact that people that are deeply ingrained in old school thinking of abstinence only, and I enjoy my meetings. I love my people. We've been, buds forever. But in the outside world, in the big picture, I'm a harm reductionist, and I want everybody to go through all the different, explore everything that's out there and find what works for you. The whole point is to make your life better. The whole point is to keep you safe. The whole point is to make a better society, So there's a little list here, but there's about 100 things. I was on a work group that worked with the Surgeon General, Vivek Murphy, who I think is going to be our Surgeon General again, on multiple pathways to recovery. And we found so many things out there that people, they refuge recovery, they are Buddhists. And then there's there's just about anything you can think of, there's kind of a recovery group. Down here in Florida, we have MARA meetings, which are Harm Reduction Works meetings that are for people on medication or not, or whoever, and it's just a recovery support meeting of sorts. And I really like that. So I'm not sure why Gretchen pulled me in with to this, but my family story is one of long-term multi-generational drug use problems, and we have found many different ways to deal with that. And I'm glad that I don't have to be called the national enabler of the Western world anymore by kids, and that people have started to embrace harm reduction. I don't even want to use the word stigma. It's not harsh enough. It's discrimination. I'm tired of people being discriminated against because they love their family or they support harm reduction or they're on medication. They're being discriminated against, and I think we should end that. And Gretchen, I can't even tell when I'm supposed to stop, because if you let me go on and on, you know what's going to happen.
You were wonderful, as were all of the panelists. Thank you so much. We did go over a little bit, and I'm happy if the questions come in and we have a robust conversation of letting it go beyond the time. I wanted to mention that the 1.5 hours CEUs are offered here, and if you look in the chat box, I put April Ella's email in the chat box. You just can reach out to her, and April, maybe you can put it in again. And if you'd like those CEUs for RNs or AOD counselors, we work with Marcy, and they're wonderful to work with. So now I'm going to open it up to questions. I see that we have one in the box already, and I think that Julia was kind of in the process of addressing that, actually. He said, has treatment changed in the last 20 years? And
the answer is, yes, God, yes. But here's the problem. Not everywhere. Like, I'm in Florida, and you would think it was the 80s here. There's still a lot of very old school treatment around. And I always say, avoid that at all costs. So Tommy, you probably know, you're in the biz.
I was just typing in, we now have more medication options. There are more pathways available, but you have to look for them. I would say harm reduction has a solid beachhead. I noticed 2019, the National Association of Alcohol and Drug Abuse Counselors, which is the professional organization for counselors, has about 20,000 members, and they run roughly 22 webinars a year. That year, 5 of them were focused on harm reduction. So I took that to be a very good sign. And there are always psychological treatments that are emerging, CBT, DBT, ACT. I mean, there's quite an alphabet soup of them. I would guess that nothing is more effective than anything else. Psychotherapy has not, as far as I know, become more effective at all in the last 4 or 5 decades. when you look at the treatment statistics for cancer, we're actually making, we have physicians who can correct me if I'm wrong, we have solid progress in treating multiple types of cancers, but in terms of basic psychotherapy, it's as if we already know what to do, we just don't do it enough. And some of these psychotherapies have been applied to addiction as well. So there is progress, and of course much more to be made. The progress needed is really more about availability than what exists.
I have opened it up so that you can all see one another, so that and if you want to ask a question, you can put it in the chat box, but you can also just raise your hand and we'll try to go from there. I know that Caroline had a question for Carla.
Yes.
So you can unmute yourselves and you can put your screens on, and we'd love to see your faces.
Thank you. Hi, Carla. So I have some amazing patients who are on MAT, and some of them have been on MAT for a long time, and they are discovering that the MAT that they're on, for example, I have a client who has been on Suboxone, who's recently discovered he should have been on methadone all these years. So is there research being done about having a more resonance with whether to direct someone to methadone or Suboxone? Because some folks are losing years because they're trying to do the right, they're trying to be compliant medically. And so, and historically, I know methadone is considered somewhat more old-fashioned, and Suboxone. So lots of people went over to Suboxone, and they might have done best to stay on methadone. Is there some clinical knowledge about how to match people to those two mats?
It's a really good question. So I just am going to take a step back before I answer it and just say to Julie's point, and I think somebody else maybe raised this as well, but I think Julia said it, that why do we call it MAT instead of just medications, right? We don't call it diabetes assisted treatment. We just call it insulin. There's no medication assisted. It's just, that's part of what the treatment is. And so I think the field has been moving more towards the term MAODs, or medications for opioid use disorder, as a slightly less stigmatizing label. But the underlying idea there is that language matters a lot, particularly when we talk about stigma. And so when we talk about the different medication options that are available for people, I think, Caroline, your question is really good about how do you try to figure out what's going to be the best option for the person. And it's really hard to sort that out because they're in such different treatment settings that they're provided in, and the people who have access to them in different ways are so different. So we do have data looking at what happens if people have a choice. So there were some studies, for example, looking at if people have a choice between buprenorphine and methadone, which one do they choose, assuming the treatment setting's the same, the access is the same, the cost is the same, all of those kinds of things. And people typically did choose methadone when all other things were equal. We can look back what we call retrospectively, where we sort of take people who are already at the end and look back and see, like, okay, can we predict who did well on methadone, who stayed in treatment with buprenorphine, who stayed in treatment with naltrexone? And so we can, it's not quite as good of data because you already have the people who kind of selected because they were successful on one of the meds, and who knows how they would have done on the other meds. But you can use some of that data to look backwards and say, okay, well, people who are X, Y, and Z tend to be more successful and stay on certain medications long term. We have certain types of outcomes that we look at. So things like retention in treatment is a big one, because whatever the reasons, whoever stays in treatment longer has better clinical outcomes. And if you look at methadone versus buprenorphine versus naltrexone, the retention in treatment typically is better for methadone. Is that because of the medication itself? Is that because of the clinic support and the other things like that? It's really hard to know what the exact cause is, but that's one clue that we sort of have, is that retention in treatment with methadone is better. I think that it's really great that we have so many different medication options. And I appreciated Elon's points. I would say the data on naltrexone for oral naltrexone is not very good. However, there are a number of studies that were even surprising to me. So my background is that, I worked at a huge methadone clinic with 5,000 patients for many, many years before I came to UCSD. And we had tried patients with naltrexone, off and on. And then we had these two huge studies that were really influential, showing that the once monthly injectable naltrexone actually helped decrease cravings and manners, even when compared head to head to buprenorphine. And that was shocking to me. And yet when we look at the data, we do see those kinds of benefits. The challenge is that it's really hard to get patients started on that medication. But what's interesting, sorry, my daughter's entering. Sweetie, I'm just finishing up, okay? What's great, I think, is that I have patients who I'm shocked that hate buprenorphine, and they have a bad experience. They don't like how it feels. It's completely different than how the vast majority of patients respond to it. And some of them really like naltrexone. I have other patients who really prefer methadone, and that's the only thing that'll work for them. I have other patients who've tried methadone, who've tried naltrexone. Buprenorphine is the right fit. So we can look at generalities across large populations and say that, relatively speaking, all of these medications are effective. Maybe methadone's a little bit better because of retention and treatment. Maybe X, Y, or Z is a little bit better because of these issues. But it's really critical that we have such a variety of meds that act and feel very different for different people, so that we have different tools to offer people, so that they can be on the right medication. And unfortunately, I don't think there is a great answer to your question, and I'll stop talking, but that we know, like, okay, I'm going to plug in this X, Y, and Z algorithm that I know about you, and you're going to be the best fit for this medication. We don't have it down to that kind of a science, but I'm glad that we have those options for when patients don't do well on whichever one they started with.
So, oh, good.
I wanted to ask something, because this wasn't brought up by anybody. During the COVID thing that's going on, my son has been able to, I know I'm losing it. My son has been able to pick up 2 weeks at a time in his lockbox of methadone instead of go to the clinic every day. And that has made a huge difference, like not only in his mood, but, here it's like an hour round trip.
Life. Yeah.
Quality of life is huge. So, I mean, I wonder if any of you guys have any thoughts about the chances we may have to open up the, get rid of the onerous regulations that go along with methadone treatment. And I mean, Gretchen and I were in Portugal, where you get it at the pharmacy, anytime.
I'd like to comment on that, because at one point my son was doing well on methadone, and for another reason he became homeless. But while on the methadone, he had to walk miles to the methadone clinic, and he lost weight and became despairing. He did not have transportation. It was horrible. And so sustaining the methadone as a homeless person was impossible. I appreciate people worry that, they're going to sell Suboxone, so don't give it to them. But that was really not a good idea, to make my son have to walk miles from his homeless shelter where he was living so that didn't work at all, right?
Especially now. Yeah. Elon, I know you.
Yeah, in the clinics now, it's a great point what you said, Julia, because now they're being a lot more open with the take homes in terms of methadone. They're not having to work so long or be clean so long if you be clean at all. And even people that aren't clean at all are getting some take homes just for the COVID safety. Maybe, if they don't get too much flashback, if they could bring down the regulation. How much of the regulation, I know they say it's safety, how much is that based on stigma? When they're talking about the question of what medication's better, and they're all better for different people.
Well,
hard to make it.
Carla probably knows this though. Methadone, she's a doctor. Methadone is the most regulated medication we have, period.
Yeah.
The end.
R-
More
Right.
regular.
Well,
But
hold on. Let
there
me just
is-
finish,
there-
and then
it
you can
is
go back.
true that people can overdose on methadone. And so there is a slight safety concern. However, from a harm reduction standpoint, I think the risk of that versus the risk of what happens when somebody's not treated is much less. So it's not that it's completely unsafe, but I do think that the regulation is not proportionate to the safety risk.
Exactly.
Okay, I'll be brief. I promise, Julie. I'll be brief.
Elon,
Just let me finish.
finishes it off. Yeah. Okay, back to Elon.
Real brief. When I'm taking a client and figuring out what medication's best for them or what treatment's best for them in general, I don't mind them being anyway, but too much the decisions being made based on stigma. There's this thing in the head that, well, maybe my family will be happier if I'm an abstinence based, so I better try that one more time. And that's how we risk in life. Maybe naltrexone isn't so much frowned upon, so I think I can make that work. Or, methadone was working for me, but people seem to think I'm dirty or I'm not doing the right thing on that, so now I'm going to switch to another one. And too many times I see people switch not based on what's best for their recovery or their stability in life, but what's based on how society looks at them. And we really, everyone says we got to break stigma, but we got to really, it takes a lot to see how deep that goes and how many ways that just affects everything. Thank you.
And I'd add that family members need to be educated with this too. And when we started this talk, I talked about how stigma runs through everything, and it runs in families as well. And that's and that's based on ignorance, basically. So we have to break through that with education, open communication. Aaron.
Yeah, interesting about the medicated assisted treatment. What I'm noticing though is, I guess the question in the back of my mind would constantly be, what's going to be the one that's easiest for them to come off of if they eventually want to come off? I know Sublocade, we've been having more success with the transition from the maintenance shot to going off, which is, injectable Suboxone, if you guys don't know. And even in comparison to the strip Suboxone, when you go from 2 milligrams off, we have a lot of pushback on and basically withdrawal symptoms, and they don't usually make it through. So that's the one part of it. The other part of it is like the question I have is when we have doctors who are suggesting that we put a client who is off opiates in treatment to put them on Suboxone or Sublocade at that point for their cravings instead of, say, naltrexone only. And I'm not a big fan of, personally, I feel like it's a disservice at that point by putting them on the Suboxone or Sublocade. I'm for harm reduction, but I would rather go naltrexone at that point. And since they're already off the opiates, would hate to put somebody on the Suboxone, on the buprenorphine when they're not even on any opiates at the moment, and the doctors are really quick to want to put them on something for craving. I understand it, but I always feel like it's a pushback for me I have internally. I don't know why, but I just do not want them to go that direction. I prefer they go to naltrexone. So I'm just curious if there's any facts about the Sublocade and Suboxone that you've known of.
So I think that the first point that you were saying about starting the patient with the idea of how to get them off, I think that is that contributes to some of the stigma already that's going on. This idea that patients should start with the end in mind. And in fact, we know that when patients come off of buprenorphine and methadone, and to some extent, I don't think the data is as good for coming off of naltrexone, but that the mortality rate goes up by at least twofold and the risk of overdose is much higher. And so while I always make it a point to have this conversation when I start with somebody, that we're starting this medication as a potentially long-term thing, and it's hard to imagine that you might need that you would want that. Nobody would. But if we start it with the idea of how are we going to get off, then I think that ultimately you're undermining yourself and you're contributing to that idea that you don't want to be on these things, when in fact you do want to be on these things because they're life-saving. And so I think that that's a really important conversation. The analogy I use a lot is with diabetes, where with diet and exercise, sometimes people can come off of their insulin or their diabetes meds, and that's fine. And for some people, they do come down and they taper off, and that works for them. But the vast majority of people need to be on them long term, and the risks of coming off are deadly. In terms of your other point about, the second part of your question about Sublocade or buprenorphine. I mean, I agree. I think that a lot of them are really hard to come down and come off of. And partly that's because our bodies, people's bodies that are used to very high levels of opioids over time, really don't feel normal without them. The reason why doctors push so much for starting somebody who's having cravings on a medication is because we know if they're having cravings, their relapse risk is very high. And that's a recipe for an overdose. And so you could easily start them on IM naltrexone. There's no reason somebody who's been off opioids shouldn't be considered for IM naltrexone, much more so than oral naltrexone, which doesn't have good data, but the once monthly injectable one does. And so there's no reason not to consider that one as an option, but they should be on at least one of the 3 meds if they're having a lot of high opioid cravings, because that's what's going to be the most effective way to prevent mortality and morbidity for them. And I apologize, I have to go. I actually have another meeting at 7:30.
A child in the room, right?
Well, there's that too.
Thank you so much, Carla.
Thanks for coming.
Thank you.
David. You need to
Unmute yourself. There you go.
Now?
Yeah.
I think I've said this before. You know, until our society recognizes that substance use disorders are disorders of the brain, are in fact, as it were, medical conditions like Parkinsonism, which is a balance coordinating problem in the brain, or like Alzheimer's, which is a dementing problem in the brain. Substance use disorders is a brain problem whereby certain people are prone to relate to mind-altering, dependence-producing substances in ways that become very problematic for them in their lives. That's the nature of that brain disorder. But until our society really accepts that that's what we're talking about, and therefore anything which reduces the dysfunction, the suffering, you know, the life-damaging problems inherent in that brain disorder as being okay, as in treatment, as in harm reduction, there will be these problems with restrictions on things, limitations on treatments, disavowing of harm reduction. You know, you can take any medical disorder and take diabetes, for example. You know, you can overdose on insulin. People do all the time. But there's no stigma attached to that. You know, there's a problem in the treatment or a problem. But when substance use disorders are looked at, whether it's by virtue of their treatment or what they cause in people, they're never looked at the way other medical disorders are. There's always has been, still is, it's better now, but that stigma, or as Julia would, I think, more correctly say, the discrimination, you know, so that people with this brain disorder, this medical disorder, are discriminated against in their treatment or anything else. And that's the biggest problem.
You know, I'd like to comment on that because a New Path marched down Washington Street. We didn't have the money to go to Washington, D.C., but in 2008, we stood with Senator Paul Wellstone for the Parity Act, which was to get Congress to recognize that substance use disorders and psychiatric illness were worthy of insurance coverage. What's fascinating is our federal government never got on board, and our son, we must have tried 7 or 8 times to get him on Social Security disability. Our son has a complex mental health and learning disability and a substance, but once, just the stigma, Dave, once the addiction was on board, they would throw it out and almost like stomp on it. Like, you're the most worthy piece of shit. You're not worthy to have Social Security disability. And our son never had graduated from high school. He never held a job. He was totally impaired. And so that's a tragedy. 2008, our Congress voted that what you're saying, Dave, that we need to recognize this. It's heartbreaking.
And I know we're running late, real quick, and to show you that there has been progress, this Parity Act, which Caroline just referred to, about a month ago, the federal government enjoined one of the biggest insurers in the country, United Behavioral Health, UBH, for not properly allowing parity in the treatment of people with substance use disorders. Some 68,000 patient episodes where they were denying the necessary treatment prejudiciously, discriminatorily, not allowing what would be permitted for a similar medical condition, and they're being forced, to do this now. So we're getting there, but it's slow.
Yeah,
I'm being a bad moderator. We're happy to stay on. We're over time right now. We did lose 2 of our panelists. I want to thank them in their absence, Tom and Carla. Thank you. Those of you that are still on, we do have another question. So if you're willing to stay on, the other panelists for a minute, we have a question in the chat box from Annalise. What do you recommend as one of your favorite effective methods of code switching to help counteract stigma and bias? That's a huge issue, and it would be helpful for everyone to have the tools to help tear down those biases and preconceptions.
Code switching? I can't hear what you're saying. I'm sorry.
I'm going to ask her to unmute so she can ask herself.
Code switching as in like conversational tactics to dismantle whatever bias someone might be approaching a person or the topic of addiction with. So not at all the same topic, but one example would be Pete Buttigieg talking to conservatives about politics. What is an effective way of doing that with the topic of addiction for people that have biases they don't realize they have and are stigmatizing either someone in their life or people in general who are suffering from addiction, fighting addiction?
So which of the panelists want to address that? I mean, it's about communication. This is an important issue. And, mine is always that there's many ways that people learn things. They can learn visually, they can learn through their ears, they can, the combination, you want to hit them as viscerally as possible. And that's why the power of telling their stories is so important, I think. But I'll leave one of the other panelists or anybody who wants to answer that question.
You start with language. I don't even use the term addiction anymore, period. The end, you have a disorder, a substance use disorder, an opioid use disorder, whatever. It's kind of, we're stuck with that word, and I'm not sure why, but I just know when I talk to people, I talk in the as much as I can in medical terms, just like I would if they were talking about their pancreatic cancer or something. I mean, this is a disorder, and It's really hard. I do a lot of interviews down here in Florida, and it's kind of like if it bleeds, it leads. You know, I can say a million things and they'll say former heroin addict says, you know, I mean, people want that. They still want to punch that, you know, the wow of it all for people that are recovering. And I don't want to punch that anymore. I don't tell people anymore. You know, I just don't. I'm in remission. You know, I like my 12-step support group, but I'm to the rest of the world, I'm in remission from my former.
Julia's right. There's been a huge movement in terms of which words are stigmatizing.
Right.
So we're getting rid of the words codependent, not based on factors science. We don't call a person an addict. If they choose to call themselves one, that's totally okay. But we like the person who struggles with a substance disorder, and get rid of the word struggles. A substance who has or a person who has a substance use disorder, and then there's a big movement to get rid of the word abuse.
Exactly.
You know, and so it's in all of our NIDA materials and stamps and materials and stuff. So there's a big movement afoot to get rid of the word abuse. It's a substance use disorder, not abuse. And the words clean, and dirty are also stigmatizing phrases that we all catch ourselves using. So it's an education to ourselves as well. But there's a huge movement afoot on this. Go ahead, Carolyn.
I noticed that I apologize for using the word relapse. I think reoccurrence, some people don't understand the point of that. But relapse, if a person has breast cancer come back, we wouldn't say that they relapsed into breast cancer, you know, the meaning that there was some kind of willful intent. So I don't like the word relapse, and I did use it, but I did apologize. I think we do need to come up with language that is non-stigmatizing, and that people would resonate with. And I have written a couple of articles on about 15 points of the language that need to be changed, and you know, I'm happy to share that with anyone.
Elon, you unmute.
Excuse me, I'm going to interrupt. I'm Merlin. You know, Elon and others got me all stirred up and so forth. I'm a person in a long-term recovery. That's my opening, and that's enough said. I tell a long story about what that means, and it's all good. But what I wanted to say is that I'm a founding member of Faces and Voices of Recovery, and we began with the premise that by our silence we let others define us. And we also determined that we're stigmatized and demoralized and discriminated against, and that has to stop. And the only way to do that is to introduce ourselves and be known and change the language. We've been talking about changing the language a long time. I've been a medicinally assisted recovery person a long time. I don't use treatment. People get turned off by that. It's necessary and clinical and all that kind of thing, but they need anything but that in their mind. And so we have to change our mind. So anyway, I just wanted to say what a joy it's been to be with all of you and to hear from all of you. And for Tom, who's been in this business a long time, and another old friend of mine, Bill White, who's written and written and written, but he began by saying at the time we had our introductory meeting on Faces and Voices, let's go make some history.
Bill lives about 20 minutes down the road.
And you all have been history making people. I can tell it, feel it, and listen to it. And thank you.
You have to, I think the best party I ever went to in my whole life was Faces and Voices in Recovery in DC. The big blowout. Oh my God, what an amazing.
Oh, you're talking, that was Facing Addiction. You mean the.
Yeah, but yeah. And
yeah.
The meeting of them all was a great event, if that's the one.
Right.
So, okay. Well, anyway, thank you all. You've been making history. Keep on doing it.
you. Thank
Thank
you
you.
Thank you, thank you, Faces and Voices of Recovery. You guys have really
very
done a
much for everything you do. Yes.
Yeah.
lot of work. We show up for you guys all the time because we love it. And
And the new Pathers members of ARCO.
yeah, of ARCO.
Yeah.
We just formed a new ARCO organization here. And so the Purpose of Recovery is alive, and we just got notice that we are a member of ARCO. And that means we get and we give back. And thank you for that too.
So I don't see any more burning questions, but I want to thank you all, the panelists and all of you for being in the room. This is recorded. I know that some people struggled to get on. I'm not sure what the technical part of that was, but yes, and some had to leave early. But that it is recorded, and so April will send that out, the link to everybody who signed up tomorrow, so that you have that and can review it again. There is a PATH holiday party on December 10th, and in the chat at the very beginning is the password and the code for that, December 10th at 6 o'clock. We have a little bit of business to do, but we're going to entertain you a little bit too with some past history and videos. So thank you so much.
Thank you, everyone.
And happy holidays, everybody.
Thank you.
Thanks, guys.
Night, night.
Thank you all
Bye-bye.
for your hard